Last but not least is from the SANS. So last but not least is the SANS lab run by Dr. Levitt and Kim. First speaker is Lehua Augello from Cal Poly Humboldt, the rising senior. I think you just got elected.
Are you guys ready for a pop quiz on that last presentation? I'm just kidding. I wouldn't do that to you guys. Okay. Hello, and thank you for that introduction, Dr. Ellenbogen. My name is Lehua, and I had the opportunity to conduct research at UW's Stroke and Applied Neuroscience Lab over the summer. Today, I will introduce you to aneurysms, CFD, the process, a specific rupture case to help exemplify the importance of computational fluid dynamic accuracy on aneurysms using patient-specific measurements. So what is an aneurysm? For those who don't know, an aneurysm is a section of arterial wall that has weakened and resulted in a bulge that balloons with blood. Leading causes of aneurysms include things such as age, gender, hypertension, hyperlipidemia, smoking, and an assortment of other issues. When an aneurysm occurs, it's at risk for rupture, which could lead to intracranial hemorrhaging, meaning blood pooling within the brain. If left untreated, a rupture could result in stroke, brain damage, coma, death, or a combination of these issues. Currently, the main methods of treatment include stenting, coiling, and clipping as seen here in this diagram. This is where computational fluid dynamics, otherwise known as CFD, comes in. CFD is applied as an investigative tool to bridge imaging and surgical intervention, utilizing computer simulations to obtain information on blood flow within the body. Uses for CFD include understanding formation, growth, risk of rupture, and treatment possibilities for aneurysms. In parallel with CFD, we utilize hemodynamics to understand the motion of blood circulation within arteries and vessels. Wall shear stress, or WSS, is a commonly used term to describe the force of flow exerts on the surface of an area. In this case, the frictional force of blood on arterial walls. So what does the CFD process look like? To start, we utilize a program called VMTK, which creates a three-dimensional model from patient images of their arteries and aneurysm or aneurysms. Once we have our segmented model, we use the STAR program to mesh it into sections for our computers to calculate the partial differential flow equations. I know that's an intimidating concept as well, but thankfully the computers deal with that. From there, our mesh model uses SPIDER to find inlet and MATLAB to find outlet boundary conditions. These boundary conditions establish where blood flows in and out of within the model. For the final step, we run the actual simulation in the ANSYS Fluid program. We look at the data and analyze it to further understand the conditions and circumstances of the aneurysm or aneurysms. You're probably wondering, what does that mean? Well, luckily for you, I'm going to subject you to a mini grand round. Before we dive in, it's important to understand the anatomy of aneurysms. You'll notice the unspecified diagram to the left displays the main arteries of the brain, while the diagram to the right indicates four main regions. The regions we will be focusing on is the posterior communicating artery, or the PCOM, and the middle cerebral artery bifurcation, or MCA bifurcation, as seen here. Now let's proceed onto the mini grand round. A 79-year-old patient presented to the ED complaining of high blood pressure with past medical history of common causes for stroke. A CTA showed 3 incidental aneurysms, but we will be focusing on the saccular aneurysm on the right PCOM, which, as you can see, is this highlighted area right here. This diagram is actually a segmented model directly from the patient's images. The PCOM aneurysm, as seen highlighted here again, was relatively small and at low risk for rupture, so no treatment was performed. It was explained to the patient that the 5-year risk of rupture for aneurysms of this size was approximately 1%. Considering surgical intervention increased rupture risk, it was encouraged to monitor the aneurysms annually using MRI imaging. At the year mark, the patient's aneurysms were screened and showed no significant changes in size, as seen here. Unfortunately, a couple months short of the second screening, the right PCOM and right MCA bifurcation aneurysms both ruptured, followed by a craniotomy with PCOM and MCA clipping. So what happened? Why did it rupture? This is where CFD comes in to help answer this question. From this case, we found that traditional parameters for rupture, such as temporal variance, OSI, and dome pressure, among other factors, were low, indicating the aneurysms were stable. Yet the spatial variance and wall shear stress gradient direction were elevated. To clarify, wall shear stress direction, or WSSG direction, indicates blood flow accelerated into the aneurysm dome. These findings actually supported a recent study investigating average WSSG direction as being a strong predictor for aneurysm growth. As seen in the diagrams towards the bottom, the red X's, indicated are specific cases data plotted against the study's data. This amplifies the notion that WSSG direction is a useful discriminator towards aneurysm growth, emphasizing the need to look for multiple hemodynamic parameters. Thanks to cases such as this one, we can study and acknowledge how aneurysm rupture can be highly unpredictable. In realizing multiple hemodynamic and clinical factors lead to instability or rupture, we understand how hemodynamic analysis can better quantify rupture risk and evaluate treatment options by supplementing imaging and clinical exams. Through this case, we can better identify how elevated WSSG direction is a strong indicator of rupture risk. To conclude, this experience would not have been possible without Dr. Ellenbogen and his lovely wife, Sandra. I want to thank Dr. Fillingham for entrusting me with the CFD project and Dr. Levitt for always being so sassy. Thank you to my mentor, Keiko, and our program coordinator, Julie, for making this so streamlined and enjoyable, as well as the opportunity to aid in research with our collaborators, Dr. Chen and Dr. Shaker. The connections I made with my lab colleagues are the support and friendship I hope to emulate in my future career. Specifically, thank you, Rin, Jahir, Michelle, Syra, and Emily for your love and support. Thank you all so much for entrusting our cohorts, past and present, to retain that desire to inspire others and remain ambitious as future physicians.